want to welcome you all here today. It's really been a pleasure to work with Sarah in this kind of collaborative arrangement, because I've been in healthcare for a very long time, and years ago this would have never happened. So it's really kind of special how things have changed and evolved, and that we can actually do some working together and helping people and being part of supporting different initiatives. And the Tandem 365 program is an awesome mixture of that, and I think will be very helpful for our families and patients in the community. So it's just a wonderful thing. I'm just going to give you just probably 2 sentences about hospice. I'm thinking most of you are all pretty familiar with what the word hospice is, and the typical Medicare benefit is a 6 months or less diagnosis best guess. Doesn't have to be. We tend to see that people are more often referred when they have days or hours to live, because it's so hard to determine that 6-month time period for physicians or for families. So hopefully with you guys being so involved with them, that you will be able to pick up on some of those clues that they have and be able to direct them to have that additional support in their home that they may, or I would assume that they would need, so we could keep them where they're at. So the agenda for today is that Sarah's going to talk about the process that we developed, and then Lee and Deb are going to talk about their disciplines, and then Amber and Heather will talk about their disciplines, so you get an overview of hospice. And Dr. Mulder will be here about 1 o'clock, and he'll talk about how do you know when somebody's appropriate for hospice, how do you do that, and how do you actually have that conversation. So that's kind of what we have on the agenda today. So anybody have any questions for me before we move on? Okay, you're on, Sarah.
Well, I think we did, as we talked about, we did sit down and have a lengthy discussion about how can we continue to work together. And go ahead and pass these around. And often what occurs is that it's an either-or benefit. It's hospice or something else. And so what we really wanted to create with Tandem was how do we make something that's better, that it's hospice and how do we complement each other, and how do we make sure that that works out in the best interest of patient and family. So we have we put a process here together, understanding that a process that we've never tried, we probably are going to have to come back and revisit and revise that process after we put it into place, because we'll say, well, that worked really well, or it didn't work well. And as a new organization, I know that that's part of what Tandem is doing all the time, is that process improvement. And also as a newer organization, we fully understand how challenging that can be, and we start a process and look at it differently. So I'm just going to talk through what does this look like. So if you identify that someone might be appropriate for hospice, and we'll get into some more of those details later, the first thing you're going to do is going to start to have that conversation with them about the value of a hospice consultation. And Tammy felt like with a level 5 or a level 6 Tandem participant, that would kind of automatically trigger you to include in your care plan an introduction to hospice visit. This isn't the traditional, okay, we're going to get ready, we're going to do the informational, they're going to sign on today. It really is more just the let's kind of get to know hospice and what it's about. Understanding that conversation, that introduction visit, probably might have to happen more than one time. And in hospice, we're very familiar with that. It's not going to be, we're going to go out and the very first time they're going to say, that sounds amazing, and I'm going to sign on the dotted line today. So don't feel like it's a bother to us to have us come out. They don't have to be fully ready for them to learn more about hospice. Does that kind of make sense as perhaps a little bit different approach than what's typically taken? You'll contact a hospice provider of the patient's choice. What we're going to talk about today, though, you need to understand has only been agreed upon by Faith Hospice and Emmanuel. But if the patient chooses something different, you can go in that route, but some of this kind of coordination we're going to get into here has not been a part of what they've agreed to as organizations. So all you really need is that face sheet and a physician's order for us to consult so that we can get engaged with the, have access to medical records, things like that. If you want, if you're just not sure, please don't hesitate to contact either of our hospices to do a pre-screen consult with you. So if you're thinking, boy, maybe this person is eligible, but I'm not sure, go ahead and give a call to the office and ask to talk to a hospice nurse so that you can kind of just talk through, this is what's going on with this patient. Do you think that they're eligible? We would rather have you contact us so that we can start to be engaged with folks sooner rather than later. And we really want to be a resource to Tandem, so if you're not sure if there's something we can help with, please don't hesitate to contact us. So the hospice provider will then come out and do an informational or introduction visit. And at that time, the navigator, whoever you on your team determines whether that's the social worker or the nurse, really should be present for that informational visit. It's a trust building time, a time for you to kind of begin that transition of the story from one provider to the next provider, because it's something we're not always doing really well in healthcare, right? That's why we have Tandem 365, because that story is not being passed from one provider to the next. And I think if we can both be in the same place at the same time, we'll more effectively be able to do that. If the participant and or responsible party is not prepared to pursue hospice, we'll leave some information with you. The navigator, the Tandem navigator, will continue to kind of talk about declines you observe and benefits that hospice might be in their care. And then the Tandem navigator will contact hospice again when you feel like they're ready to kind of have another conversation. And again, we will come and introduce ourselves as many times as we need to help them in that decision-making journey. So if they are really ready to pursue hospice, and that may happen on the first visit, then we would coordinate with the hospice to have a registered nurse do the assessment. And we would really like for the Tandem RN navigator to be present when the hospice nurse is doing that assessment, so that some of the little stuff that you've noticed and picked up on can be included in that eligibility assessment. Does that make sense? Anything that you're kind of like, oh, that's a red flag, I'm not sure that'll work?
So even for the informational, we have to have a doctor say they're hospice appropriate. We need a doctor's order for the information.
We can, if you want us to look at their medical record, that's kind of we can come out and give information to anybody anytime without a doctor's order.
Okay, that's what I was sort of
Yes.
getting hung up on.
Yeah, no, if we don't need a doctor's order, right, to come and do the information piece of it. But if you want us to start getting into the medical record and put our hands on the patient to do the physical assessment, that's when it crosses the place where we do need to have the order. That's your practice as well? Okay. All right, anything else? That was a great question.
Thank you.
Okay, so there still might be a chance that they'll come out and we'll gather all the information, and there still might be a determination that perhaps that person doesn't quite yet meet eligibility criteria. Okay, so if that happens, we're going to complete for you what's called a non-admission follow-up plan of care. And we'll tell you, the navigator will know at the end of that assessment visit, what do you need to continue to look for as signs of decline that would make this person appropriate for hospice. Okay, so we'll leave that with you. We'll take one back with us and we'll agree upon, who's going to follow up when and next. And that's going to be different for every single situation. So we're trying not to put too much must and always on this practice. If they do meet eligibility criteria, then we're going to go ahead and begin that transition from Tandem 365 to hospice. And so we've had some of those already that have gone from Tandem to Hospice, and we did it in the more traditional either or. Hospice came in, Tandem went out. And so what we're proposing here today is that we not do that. That the person's not going to officially be discharged from the Tandem 365 program until the time that they die. Okay? So how are we going to do that, right? Does that sound good? Does everyone like that idea? Oh, good. So kind of how we'll look, and this is where we're going to have to be creative and really work together and co-case manage and think about what's the best for the participant. Okay? Not get kind of caught up in, well, that's not how we usually do it. The goal here is to look at a different model of how do we do this. So the Tandem navigator and the nurse will make joint visits for the first 1 to 2 weeks, but again, the navigator and the case manager can think about what makes most sense for that person, okay? And then after the joint visits have stopped, the hospice case manager will contact Tandem and give them kind of an update on what's going on. But hospice will, because of our regulatory, we really need to become primary for that case management piece. But it doesn't mean that you can't continue to be involved in their care. Okay, so the number we'll want them to call will be the hospice 24/7 number, not the Tandem 24/7 number. Okay, so we'll be responsible for going out and taking care of their needs after hours, weekends, holidays, etc. And if there's been a major change, then we would contact you just so that you're aware of what's going on. With the personal care services, hospice will transition that out, but recognizing again that we need to have a good transfer of knowledge, because we all know when someone has a personal caregiver that they really love, that's doing a great job for them, that knows all the little things. It's hard when we invite someone new to do that very personal and private care. And so what we want to set up is a couple of visits again where we have the hospice aide and their personal care aide, work together to provide the education and do that handoff. And we did talk about there might be some cases, right, Tammy, where maybe we would decide that's not the right thing. Okay? So this is very individualized based on what does your participant need and what's in the best interest, but also being cognizant that we need to be good stewards of the resources for Tandem 365, right? So we don't want to just say, well, they don't want to change, so we're going to keep this other personal caregiver in. Does that kind of make sense to everybody? There has to be a really good reason why we would do that. And then what we'll do is kind of sit down with those care plans, at that admission visit, sit down, integrate pieces of the Tandem care plan into the hospice care plan, and vice versa, the hospice care plan into the Tandem care plan. Maybe someday we could get to a place where we could really just work from one plan of care, that we don't have to kind of live in this world where we have separate. And I think that, this is all of these are really good first steps for having hospice plus care. That's really what this is. And I think that, as we continue to work through this process and work out the bugs, that would be probably the next thing that we'd look at, is just having the one care plan. If the Tandem hospice, or if the Tandem medical director is the primary care physician for the participant, they will remain as the PCP. Hospice, so does not require people to change to our medical director. It's just an option for them if they either don't have a PCP or are just not satisfied with the care that they're getting from their PCP. But I'm sure long before they come to us, you all have that PCP thing all worked out, right? Okay, any questions about any of that? All right, the other thing that we're going to work on is that if they have a Tandem 365 volunteer, we just have to work through some of the process and making sure that we're meeting all our guidelines. Heather's starting to sweat a little bit in the background there. The plan will be that we'll give them a hospice module. okay? That would be just one additional perhaps hour on top of the training they've already gotten through Tandem 365. Not that they can continue because they're still a participant in Tandem 365. However, if they want to be integrated into the hospice care plan and for us to be able to count their hours, we have a requirement that we have to have a 5% volunteer match hour to our worked hours. And so if they really want to be counted in that part, then we need to think about, okay, how do we make sure we dot all our I's and cross all our T's, so that we can have them kind of really operating in both worlds. Okay. How's that sound? Go
I
ahead.
just have another question
Yeah.
from my previous world. If a person lives alone and really has minimal support systems, is it appropriate to refer to hospice?
So what hospice doesn't become is the 24/7
Right.
primary caregiver in the home.
Right.
And I think that's really an individual-based question. That wouldn't make someone not an appropriate referral, in my mind. They need to know that it doesn't become, well, we're gonna call at 1 o'clock in the morning because I've been incontinent and I choose to live by myself. Those are some of the kind of nuances, is we don't replace primary care, we're in addition to the primary care that already exists. And sometimes people will say, I know I would rather be in my home with less support, perhaps in a situation where it's less than ideal, but that it's more important to me to die in my home than it is for me to make sure that I am cleaned the minute I am incontinent, or to have someone there all the time just in case.
So you will enroll without a primary caregiver?
It depends on the situation.
Okay, because where I came from, way back
Yeah.
when, it was like, don't refer if they don't have a caregiver.
Well, I mean, that's unfortunate.
I mean, no, that wasn't here, that was in another state.
Yeah.
That was kind of like,
That has been the practice in a lot of different hospices.
Yeah.
That is not the practice in either one of our hospices here.
Yeah, I mean, we want to help give them, the philosophy is to educate, to offer options, and then to honor their wishes the best we can. And sometimes, as you know, because that's a lot about what you're trying to do too, that's very hard, because as caregivers and medical professionals, we see people living sometimes in environments that are less than what we would want to live in. But part of our philosophy is to embrace that it's not about us and our journey, it's about them and their journey and what's most important to them.
thank you.
Any other questions? All right, well, we have different team members from hospice that are just going to give you a little snippet as to, what it will look like to have a hospice first. Let's go ahead and start with Deb. Okay.
The hospice nurse case manager is the primary leader of the interdisciplinary team for that particular patient. So we have nurse, chaplain, volunteer, social worker, sometimes bereavement, and all the other people that get into the house. Why do we need them? And Sarah had mentioned about educating and offering options. And really, that's what the nurse does. She assesses the situation, both physically and whatever else is happening in that household, caregiver, social, all the other little facets of that person, and then communicates with the rest of the team. But mostly her role is to offer options for physical comfort and care, and to check back and make sure that we're meeting the goals to take care of those symptoms with interventions that the patient and family like and approve and are going to use. And to be that constant communicator to figure out what's the new thing that's happening, what do we need to work on today, how did it work with what we did for you, and what do we need to do to prepare for getting ready for the next couple of weeks. So always fluid, always dynamic. Sometimes we visit once a week for someone who's pretty able to manage their own symptoms, and sometimes we have to get out there more than once a week. We do a lot of crazy things in the house that we used to only do in a facility, like pumps and IVs and tube feedings and all of that stuff. So really, how much we are involved, it really depends on that patient's individual circumstances and how much trouble they have with the troublesome symptoms of end of life. So a lot of communication between the physician and everyone else to make sure that we have everything in place, getting meds in the house for them, teaching them how to use them, making sure that they have the appropriate medical equipment in the house, teaching them how to use them. I kind of see that role as really the educator and troubleshooter, and trying to figure out how to prepare them for what's coming up. I know it's not a very complex explanation, but really simply, that's what we do. So it's always being prepared for whatever comes up. And even if it's that middle of the night thing where, we didn't put something in place, you guys are all shaking your heads. We didn't put something in place because we didn't anticipate it was going to be a problem. Then we would send our after-hours care team out there to assess the situation, get things in place. Sometimes that means transferring somewhere else temporarily or providing constant in-home care to get those symptoms under control, and then putting a plan in place for how they're going to manage it in their own space. Do you guys have any questions about the nurse's role?
I think the other thing is if you get contacted by a Tandem participant that's enrolled in hospice, you're gonna take the information, listen, and then get in touch with the hospice case manager so that you can come up with the best plan together. Because sometimes if you are trying to deal with it during the day, you don't know what. Perhaps we did something at night that changed something. So just making that call before getting into managing the plan. Okay.
Lee, you want to go next?
Sure. By the way, do we look familiar to you guys at all? We were on that Terry DeBoer show.
Oh, no.
My name is Lee, and I am one of the chaplains with Faith Hospice. I'm an ordained minister, did that for about 26 years, and about almost 8 years ago I decided to become a hospice chaplain. It's a poor analogy, but I feel like I've died and gone to heaven because what we do is just so significant in people's lives. I have the privilege of being on 3 teams. Deb kind of talked about the fact that there's a physician, a nurse, social worker, chaplain, aides, that sort of thing. I'm on the hospital team, so I see patients in the hospital. I'm on a community team, I see patients in the community, and I'm also at Trillium, and so I see patients at Trillium. So this could be the flow. You could have a patient in their home, sign up for hospice, and I see them in a home. Symptoms will get out of control, they may get admitted to the hospital. Once those symptoms are managed, they still may need care above and beyond what could be done at the home, and so they move to Trillium. So it's kind of an extended prognosis kind of thing for that. My wife and I raised 2 daughters, and for those of you who have raised daughters, as a chaplain, I'm here to tell you that you have a direct ticket to heaven. You have picked up the to-go and collect $200 card. And when our girls were both starting to drive, I signed up for AAA, road service. And the reason I did that is because I wanted somebody else to get that call at 3 o'clock in the morning at the Taurus station wagon had a flat tire. Unbeknownst to me, what AAA has is something called a triptych service. You familiar with that? It's like you're in Grand Rapids and you want to go to Bradenton, so they give you this triptych map. Right? So you tell, okay. As a chaplain, my role is to, first and foremost, I never ask people what religion they are. I ask them if they're people of faith, because I believe that all of us are spiritual beings. All of us have some concept of where we started and where we're going to end up. And so as a chaplain, my role is not to take my triptych and place it alongside yours. And from a spiritual standpoint, tell you where to turn, tell you where to stop, tell you where you went off the road. My role is to figure out what your triptych is and try to give you spiritual support along that journey. And that's done in a variety of ways. That can be done just simply with companionship visits, just ministries of presence. Oftentimes it's prayer, it's scripture reading. We're involved in some more complementary kinds of therapies out at Trillium. So there are a variety of ways in which I help people find comfort spiritually wherever they find that. Does that make sense to you guys? Any questions at all?
Excuse me, pardon me. Yeah, we have a question. Where's Kathy's phone?
Okay, we're good?
Okay. Amber.
Thank you.
In the back seat.
Okay. My name's Amber, and I am the social worker. And my role as a social worker on the hospice team is kind of chameleon-like. And we go through with our team and are for the patient what they need us to be. And so kind of like the chaplain, if I go to a patient's home and they're really struggling with a spiritual dimension of their life and their death, then we focus on that day. Or if it's something related to a deep-seated physical or emotional pain that they've sustained in their life that's really coming up and preventing them from being at peace and letting go, then we focus on that day. If it is working with the family more so than the patient, then we do that. I kind of joke, but am serious when I tell patients and families that I can do anything that's not medical. So short of taking your blood pressure, we can find a way to work anything else out. And my job is to find out who this person is outside of their illness. And they, most of the times to this point, have been reduced to a diagnosis and a room number. And while those things are an important piece of what goes on, that's not what defines them. They're defined by, I'm a mother, I'm a daughter, I'm a, whatever it may be. Let's find that. Yes, we know that this is happening. We don't need to beat it over the head. And we have many great discussions and many wonderful laughing times, and hospice is not all, tears and anxiety, and yes, we are on call for that, for the times where you feel like you can't go on and where you feel, you know what, this is terrible. I don't want to live anymore. I don't want to live like this. Okay, tell me how that feels to you. What does that look like? And yeah, this is terrible. And so acknowledging and really giving people the purpose back in their life that you are a wonderful creature and you are important and you still have value, even though you're laying in a bed and you don't feel like you can. That there's nothing else for you to do, and I am defined most of the time by what I do. Everyone asks you when you first meet, well, what do you do? Well, what do you do? Well, when you can't do anymore and you're just being, then what? And so it's giving people back that dignity that they deserve and giving them their humanity back. That's the big good part of what I do. We also, social workers have to have all of those resources or have their finger on the pulse of the resources to help the families when you have in the middle of the night they fall and they break their hip and they're in the ER, and then the next morning comes and we are not able to stay at home any longer, and what do we do? And we've got to have all of those things. We're there to, it's okay, we're good. Here's some things, here's some places to call. I'll get on the phone, we'll get a mobile x-ray, we'll do whatever it is that we need to do to make sure that this patient and their family have peace. We'll take all of that. We'll take, it's a bad and a good day when you get all the anxiety put onto yourself, but at least it's not on to the family, and they can rest at night knowing that they have done everything that they could And like Sarah said before, it's not about us. It's about giving the patient and the family all of the resources and then advocating for them in that decision. We may not like that. We may not agree with it, but if someone is alert and oriented and able to make those decisions, they have the right and the responsibility to do so. And so we go to bat for them. And even if it's having wonderful, kind words with our other staff members about this is why they should be able to do this and this and this, we will do it. So we are wonderful advocates and elicitors of that story that everyone has. And given the chance and the ability, they will share with you. And it's quite an honor, and we feel very privileged to be allowed to be in someone's home at that time. So that's what we do. Any questions? Okay.
It's a hard act to follow. As I mentioned, my name is Heather O'Brien. I am the Director of our Bereavement and Volunteer Services at Emmanuel Hospice. I'll just start with talking about volunteering. Being a hospice volunteer is much different than most any kind of volunteering there is, in that, as Sarah mentioned, we are very highly regulated. There are laws, lots of hoops and papers they need to sign before they can even be in the presence of a patient. So we do take that very seriously, and because of the time of their lives that these patients are in and when these volunteers are with them, it is important that they're very trained and ready for some of the situations or questions or things they might observe. So we do a pretty comprehensive training for all of our volunteers. And as Sarah mentioned, you'll be training your volunteers, and I'm sure we can work together if they would like to continue. As she mentioned also, Medicare requires at least 5% of the hours that are provided by volunteers. So it is mandated that we have volunteers in hospice, which is a good thing. Hospice was started by volunteers, so it makes sense that they're an integral part of what hospice is. My memory fits on a piece of paper like that. Our volunteers provide a myriad of different things. They provide respite, music, companionship, art, spiritual support often, and as was mentioned, just being that presence is just a huge gift that our volunteers give to our patients and their families, because they know that that person is there because they want to be, and that they understand that this is not a great time in their life, and they may not want to talk that day, but they're willing to just sit with them. And I think that's really important to remember that volunteers aren't always visiting. Sometimes they're just that presence at the bedside. We do also provide vigil volunteers, so if a patient does not want to be alone, or a family needs a break, and that patient is imminent, or we think they're imminent, we do our best to get someone there, and I'd say 99% of the time we're able to provide those vigil volunteers, and those are just so appreciated by the families and the patients. Another thing that our volunteers do is they help with bereavement, and for our bereavement services, again, Medicare requires that we provide at least 13 months of bereavement support to any family member, caregiver, friend that was involved with that patient that would like that support. So that involves making calls, mailings, visits, sometimes counseling, depending on what their needs are for that situation. And I have bereavement volunteers that help with those calls, help with those mailings as well. So that's another way that volunteers are kind of entwined with our bereavement program. We provide bereavement support to the community as well. Anyone can walk in our doors and say, I have had a loss and I need some support, and that's what we're there for. And we also can provide support to facilities, caregivers, facility caregivers is what I meant to say, or other folks who might need that support as to, this is really hard. We've been caring for this person for 6 years and now they're dying, and it's like losing a piece of your heart. So that is a very big part of our mission, is that we can support all the folks in our community that might ask for that support. Did I miss anything? Questions?
Is that a covered benefit by most insurances if they've not been enrolled in hospice? If you're talking
The bereavement?
Mhm.
No, that is something we provide at no cost.
Okay.
We take donations. Any other questions?
Okay, you're up. We'll have Dr. Mulder, he's here early and we're early, so we might as well just proceed on and make copies of his PowerPoint and...
Which may not be exactly what I'm going to do, but we'll come sort of close to that. I see there's a projection. Are we planning on projecting something?
I wasn't sure if you needed it for...
I didn't know if you would bring the computer and want to project your slides.
I did not bring my computer.
There you go. So that's...
Then we're all
So-
set.
Okay. Okay, well, as the folks are transitioning out, so I was not here at the beginning, and so I was not here for the introduction. So I'd like to know who y'all are.
I'm a social worker. My name is Julie.
And what do you do, Julie?
What do I do? I work here at Tandem.
Okay, all right.
Need more than that?
No, do you have any experience or exposure to hospice in the past?
Yes.
Okay, so you had some hospice experience.
I'm Lottie. I'm a nursing student. I go to school down in Florida. I'm here doing intake and surgery for Tandem.
Okay, you're doing that as a job or as an internship?
As a job.
Got it, okay.
I'm Andrea. I'm a social work navigator for Tandem.
I should ask, either of you have any hospice background or experience?
I did one clinical rotation with them.
Yeah.
That's about it.
Okay.
I did a year-long internship.
Okay, that's fine.
Kathy Tillinger, social worker for Tandem 365, both personal and professional with hospice.
Okay, excellent. And you'll be working as a navigator then?
Yes.
Or- Okay.
Karen Charles, and they're a navigator with Tandem 365.
Okay.
Not have any other than personal experience with
Okay.
hospice.
Social work navigator had experience referring to hospice several times, as well as palliative care.
Okay, so no direct work in that, but just peripherally you work with them, but
Referrals,
not in them.
referrals,
Yeah,
yes.
okay.
My patients, my clients, yes.
Okay, great. And
I'm Tammy Kroll. I'm the clinical administrator for Tandem 365, overseeing the program.
so you're kind of in charge here.
So far today.
You got a manual badge on there.
Yeah, Doctor, I'm the Director of Community Outreach. My name is Ryan Goodwin, and
Okay.
I've had personal and obviously professional
Well,
experience with hospice.
as you saw the tag, so I don't want to go on breakfast figuring that. You've got some connection there, yes.
Joan Ryder, nurse navigator for Tandem.
Okay, great. So I've got 3 different directions I can go here today, and so what I really want to know is to understand what would be most valuable from your all's perspective, because I understand that we're kind of part of what we're talking about today globally is what is the role of hospice in the care of these patients, and so that gets to how do we figure out things like prognosis? Is that something that's important for us to know in terms of how we monitor and manage people through a trajectory of an illness? Another thing that we could be looking at is hospice eligibility. What specifically qualifies someone for eligibility into hospice services? So that's another thing we can talk about. We can talk about, you mentioned palliative, when you mentioned palliative, yeah. So we can talk about what is the role of palliative resources. My assumption is that in the context of the navigation that you all will be doing, the work that you'll be doing with your clients, is that your responsibility will be to understand what all the different resources are out there that could be of potential benefit and value to your patients. So I always include palliative in there because by definition, we're dealing with patients that have some element of complex, advanced, or chronic illness. And in my world, palliative needs to be a part of it. So I've got that on my list of possibilities to talk about also, but I don't know if you've got a whole nother session planned on palliative, so we don't need to necessarily address that right now.
Not right now, we don't have a whole nother session.
Okay.
Probably, the priority would be the eligibility piece,
Okay?
and then the first thing.
Prognosis.
Yeah.
Okay, so it sounds like all of them might be relevant.
Yes.
Yes.
Okay. So how much time do you guys have on your calendar for me to be here?
Till 2.
Till 2 o'clock.
Oh. Yeah, let's go. Okay. So if you've got it, in fact, I should probably, is there an extra copy of that? Yeah. So I can refer to the. Okay, so if you get away from the title slide and look at that first one, there are really 5 different domains in healthcare generally that we think about. The first one there, keeping healthy. That's, there's a lot of stuff that you see on the internet, and there's a lot of media, and there's a lot of focus on getting healthy. I just had a patient came to clinic yesterday, and in an attempt to try to enhance their health, they bought some products from some company out in California, kind of sight unseen, hundreds of dollars. And then I said, well, what is it? Well, they didn't know, so I got a series of emails last night with pictures of all the different bottles. There were 8 of them. And I'm going to estimate that they spent somewhere between $350 and $400 on those bottles, which had virtually nothing that was relevant either to their overall health or to their disease status. But they were so desperate because they want to be healthy. So we see these things, and there's a lot of focus on being healthy. The medical care system, for the most part, ironically, doesn't deal as much with being healthy. They deal with the second, third, and fourth items on that column. If you can't quite read them, one is detecting health problems. So that's where we started getting to screening. You're going to your doctor because something ain't quite right, or you're not feeling well. The next one is diagnosing diseases. And certainly a lot of what we do is trying to figure out what really is going on, and then certainly in treating diseases. So we as physicians really get much involved in the diagnosing and treating of diseases. The large box on the right there, providing for a good end of life, is something that really needs to be an encompassed part of everything that we do. And so that's going to be a nature of everything that you do from the first day of the patient, that you interact with the patient. I had a doctor, I was speaking once, and he said to me, boy, I could never do what you do because I could never work in a practice where all my patients died. And I stood there silent for a little bit to see if he realized the idiocy of what he said, and he didn't. And I said, I'm fascinated. I would like to meet some of these patients of yours that will never die. Oh, you know what I mean. I said, no, let's talk about that, because it really is, you're taking care of sick people. They're all going to die, and you are sitting here blatantly denying that reality. So as soon as they enter the program, we need to have in our mind these patients at some point in time under our care will be dying. Most of the time as a result of the illness they came in on, and sometimes with something else that may come up or an acute event that we can't predict. So how are we going to help them negotiate and navigate this reality of that particular circumstance? So I will skip over that next one that talks about I've got three or so things that talk about palliative approach. We're going to skip over that. I'll come back to that later. I want to go down to the ones that talks about prognosis. And then I'm going to get into some things that I don't have slides for, but that's okay. You don't need the slides because a lot of our talk about is conceptual here, okay? So it says traditional duties of medicine. This kind of gets back to the first one, to diagnose and to treat. The third one there, the PX stands for prognosis, as accurately and as empathetically as possible. And prognosis provides a context in which medical decisions are made. How we deal with patients and what we recommend as physicians depends in large part to what do we think the possibilities are, and what do we think this is going to do for the patient, and what do they really need given their prognosis. I would also state that we as physicians are terrible at prognosticating. It's estimated that most physicians, the studies that have been done, overestimate prognosis by a factor of 5. Okay, so if your doctor says you got 6 months to live, it's probably not nearly that long. If he comes in and says, the old joke that says, call from the doctor, says, what's up, doc? Well, I got bad news, I got worse news. He said, well, what's the bad news? He said, well, you got 24 hours to live. Well, what's the worst news? I should have called you yesterday. So docs are notoriously lousy at prognosticating. And we need to understand. I don't do numbers myself when I talk to patients about that. We talk about the reality of their diagnosis and the expectation that they can't survive that. So let's talk about what does it take to live life well between now and when that end moment comes. What do we need to introduce into your life that makes sense and that helps to promote and instill a good quality of life? And what do we need to remove or prevent from coming in that could actually detract from your quality of life? We've got a lot of stories that I'll talk to you about as we move along there. The reality is that over 80% of the patients really want to know, and they want to know from their doctor what's going on. And they really want to have an idea of, I tell people, we're not going to check days off of the calendar. We can take a look at some general things, and I'm going to talk more about that specifically, that help us understand, is this something we need to be thinking about preparing for today, or in a few weeks or a few months, or do we have years down the line? Some say, well, we're all terminal. Well, that's just kind of a flippant response to say that doesn't really acknowledge the reality of what may be going on at that point in time. So, when is an illness actually terminal? And that becomes sometimes a legal term, sometimes an ethical term, sometimes a regulatory term. And so I don't really so much get into that, but just so, for the purpose of thinking about what makes an illness terminal, it would be something that would be incurable. We cannot fix this no matter what we bring to the table. And it is going to be progressive. And if this thing runs naturally, most people use a year to define terminality. That's different than hospice eligibility, but to say, boy, if we think that this thing kind of runs. Now, again, that's a generally accepted term, but I work in an ALS clinic, and these patients, from the time they come in, we know they're going to die from their illness. It might be 2 or 3 years. Does that mean they're not terminal until they hit that 1-year point? Of course not. And so there's no points in, we don't draw a line in the sand and say, oh, you weren't terminal today or yesterday, but today you are because you crossed that line. So we don't get so much bothered about that. But just in general thinking, you know what, we've only got a few months or maybe a year or two to think about how we're going to live life, because life's not going to last much longer. So we're going to talk about, if you flip down to the important considerations, when is illness terminal? I want to talk about those specific considerations there. This is where you don't have the slides, but that's okay. I'm going to just kind of walk through these. When we talk about the things that can impact prognosis and terminality, so that as you're dealing with your patients, you can kind of take a look and say, oh, this might make it a little more urgent to consider this, or relax, we're okay for today. There are things that are non-modifiable, things like gender, age, things like that can impact prognosis. And that's pretty obvious in terms of the age. If you've got someone who is 94 and has end-stage COPD, it's different than if you have someone who is 38 and just has a little bit of asthma. Well, they technically both have COPD, but the age in and of itself imparts some element of prognostic implication. I had someone, I was taking care of a 97-year-old lady that was in hospice, and she was being cared for by her 104-year-old sister, who was the primary caregiver. So when I asked about primary care, she was the patient's primary caregiver. She was sprite, she was active, wasn't real strong, but didn't need to be. She did a great job caring for her sister. We got some blood work back on the sister, the caregiver sister, that indicated she probably had developed an acute decompensation of an existing chronic leukemia. Very limited prognosis. And when I sat down to talk to her about the fact that we'd like to get hospice services in for her too, she first kind of seemed surprised. She said, well, I feel fine. She says, but then again, at 104, how much longer do I think I'm going to live? With or without an abnormal blood test. Age does confer some element of that. Functional impairment. Again, think about what they can do and what they cannot do, and how that impacts their potential for not only living well, but the potential progression of disease. People who are functionally impaired, there's impact on possibility for injury, falls, things of that sort. There's possibility for increased risk of thrombotic complications and blood clots. There's a potential complication for increased risk of infections, decubitus ulcers. So that level of immobility and functional impairment leads to an increased prognostic risk. Something like diabetes and other chronic diseases that can go along with their primary disease has an implication in certain circumstances. Some are pretty obvious. If you have someone that comes in and they have a cancer diagnosis not going to be treated, if one happens to be, you have two people, one happens to be with chronic renal failure on dialysis and the other doesn't, the one with renal failure probably has an impact on their prognosis because of that comorbid condition. Poor nutritional status. If we don't have the necessary substrate in the body to help to sustain and to build, then the prognosis is going to be limited. And one of the realities on nutritional status, just as a parenthetical comment, a lot of people focus on that, and a lot of times family members will focus on this, trying to encourage and get people to eat. Or you will have nutritionists and dietitians who will kind of come up with this wonderful formula. Well, they need 2,248 calories, to be ideally maintained. Well, that's really kind of bogus. Because it doesn't take into account the comorbidities, the underlying circumstances, prognosis, anything like that. Nutritional competence is important, and we want to make sure that people are being nutritionally managed appropriately. But we have to remember that for many, many, many chronic disease states, many of the things that your clients are going to have, these folks are going to be nutritionally compromised on the basis of the fact that their illnesses they carry what we call a catabolic weight to it. They have their body consumes extra calories just to survive, and the illness has an energy need as well that draws on those calorie stores. And so you've all probably seen people who have cancer, who seem to be eating fine, taking in food, and they waste away to nothing. And you can measure that. You've got some of them have 2 feeds in, and you pour the calories in, and they still lose weight. Well, because the system changes. Chronic disease changes the system such that we can't stay ahead. I don't care how many calories you put in. They're not getting to where they need. They're not producing the necessary energy source to build someone up. So understand that when someone begins to get nutritionally compromised, yes, you want to take a look at what are they eating, how are they eating, does supplementation make sense in terms of Boost or Ensure, some of those things. I personally like Carnation Instant Breakfast with the scoop of ice cream. It's a whole lot better than that other crap. But it tastes better. It tastes better. So different ways of helping to support them nutritionally. But these are not the things, when we start focusing on that, we lose the big picture. And that's really the deal here. Just understand that if they're starting to get nutritionally compromised, that does have an implication on their prognosis. So that's comorbid conditions. Tempo, and this is one of the really, it seems kind of obvious, but it's also one of the simplest ones. When we think about how fast is the disease progressing, and I simply look at it like this. If I am able to witness significant decline changes within a matter of days, well, we have a prognosis that we measure in terms of days. That's, if I see them today and I see them a week from today, oh my gosh, I'm seeing significant changes. We're going downhill, presuming that there's not some sort of a conflicting thing that is a fixable that's caused this. If we see them, week to week doesn't seem so bad, but boy, I saw them today and I saw them a month from now, and they seem to be, just a few weeks has made a significant change. We measure their prognosis in weeks, and on so. So if we go, I've seen them now, I've seen 3 months, not so much, 6 months, I'm wondering, 9 months, boy, I really see changes from when I saw you in January, and now it is September, and I'm really starting to see something measurable. I had a patient in clinic yesterday who was concerned about meeting up with her kids that are off from out of state. They're coming in 2 weeks, and she hasn't seen them in a little while. The last time she saw them, she was able to walk on her own. Now she's using a walker. Okay, now it's taken about 6-8 months to get to there. But so she has a prognosis that we would measure a whole lot slower in terms of how she's progressing with her ALS. And then, of course, years is the same way. We know they have an illness. We're not necessarily seeing much change from time to time, month to month, but we know that they, in fact, can't survive this. So we measure that. And that trajectory, it's never exactly linear. Okay, it kind of dips, and sometimes it goes more rapidly. Sometimes it plateaus out a little bit. So just keep that in mind also. So that's tempo. Agendas. Whose illness is this anyway? Whose life is this anyway? Everybody comes into this illness with a particular agenda. The patient themselves may have a good understanding of what's going on. The family members may have something very, very different in terms of what they think is going on or what they want to happen, and therefore what they make demands on the system for, what they're asking for in terms of intervention, testing, hospitalizations, all these sorts of things. Or you may have them saying, no, mom's not in pain, and mom might say, I'm in pain. Everyone has their different agenda in terms of how they approach and how they look at it. So there may be non-acceptance of the illness itself. There may be some mistrust of healthcare professionals. I did a home visit earlier today on the way here, and as I was talking to them, and the lady who was a patient asked if I knew this particular doctor. I didn't. In retrospect, I'm glad I didn't. I said, no, why? He says, well, because he killed my daughter. Oh, that's interesting. What would you like to share about that might be helpful for me to know while I'm sitting here in your home, you know? So the people may have different perspectives of the healthcare system, what they can and can't do, that might motivate them to either glom on and say, this is exactly what I want, or might say, I'm suspicious, I'm distrustful, doctors are nothing but, money-grubbing leeches, and I don't trust the insurance companies or hospital systems, so they go online and they buy 8 bottles of gel. So that may be an agenda that influences your ability to help to navigate their care. Out-of-pocket expenses can be a huge issue for people as we're working through this. Now, I've not really spent time studying the nuances of the Tandem 365 financing system in terms of what patients are still responsible for, but that is an agenda that can really dramatically impact someone's choices that they make in terms of how they pursue the care. So that's agendas. Will to live versus resignation. Those of us that have worked in end-of-life care, and even with chronic and older folks, have seen folks in whom they seem to be able to hang on for longer than what their prognosis would suggest that they should have. And also, we hear this term about giving up. And people decide, families are concerned about that all the time. And we talk about hospice, we'll touch on that a little bit, but where they say, well, I can't use the hospice or I can't be injured because if we do, they're going to know they're dying and they're going to give up. So the question is, do you think there are circumstances in which our will can influence the timing of our death? Anyone believe that? Yeah. Okay, everyone does. You're right, it absolutely can. It certainly is not a be-all and end-all. If I'm, healthy and doing fine, I'm just deciding, someone comes in. Otherwise, teenagers who break up with their girlfriends would be dead all over the place, because I can't live anymore, I just don't want to live anymore. They lie down, and of course they don't. So, but in the context of a terminal illness, are there some existential issues that play into how we approach it? Yes, it is. It's not so much that we're willing ourselves to live or willing ourselves to die, but the tight intertwining of our psyche and our physical body is mysterious, and it's fascinating to me. I'll just tell you one story just because it's a great story, and that influences this, or emphasizes this point. This is a lady that came into our hospice facility when I was down in Tennessee. And she had a GI cancer, lived alone, mid-80s, progressed down to the point where, okay, it's really clear that she really can't take good care of herself, came into our facility, and continued to rapidly decline. She got to a point now where she was no longer eating or drinking anything. I mean, nothing. And so we kind of, in our minds, were thinking, okay, we just have a few days left. She got to about a week and a half, and she did then lapse into an actively dying phase. And again, for those of you who not have direct involvement with hospice, that's a particular time in we recognize clinically as which their vital signs are changing. Their heart rate is hard to feel anymore. Their blood pressure has dropped. Their breathing has dropped. They're no longer conscious. They're no longer producing urine. A lot of things that go on in terms of organ system shutdown. Just think about the fact that the system's shutting down. That's an actively dying state. By that time, her son and grandson had come into town, and they were sitting at the bedside, and said to me, so Doc, how much longer do you think? And my mistake, of course, was saying, well, a couple, 3 days, that's kind of the average for people in actively dying state. And, you know, for her, she has not been eating or drinking for a week and a half. So, a couple, 3 days. I was really confident about that. So 2 or 3 days went, 4 or 5 days went, 6 days went, and she's lying there breathing for a minute, completely unresponsive, not producing urine. And they're getting very, very irritated. You know, doing the bedside visual, you know, and they got, you know, work and home and life to get on to. And grandson, is there not something you can do to put her out of her misery? I said, well, she's really actually quite comfortable. We can talk about putting you out of your misery. She's very comfortable right now. And so a week goes, a week and a half goes. I mean, I would get up in the morning and I would just, I didn't get the call, which means I'm going to have to walk down into the unit, go into the room with this very peaceful, very shriveled little lady and 2 angry men at the bedside. And that went on every day. Now, keeping in mind at a week and a half, we'd already had a week and a half prior to that, nothing to eat or drink. So now we just kind of closed the physiology text and pushed it aside because now you were, you know, involved in psychological care and spiritual care. We coursed at all the things that you do in a good hospice. Is there work undone? Relationships unresolved that need to be, you know, spiritually she wrecked with God, all that sort of stuff. And everything goes good, good, good. No, 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 no problem. We're fine. Okay, so 2 weeks comes and goes. Now we're 2.5 weeks from actively dying. Okay, add to that a week and a half of no intake. I mean, this is just so far off the charts that I just can't even believe what's going on. Mm-hmm. I'm walking down the hallway and there's a young lady standing outside the door, like this, you know, and looking at me as I'm walking down, and she says, "Are you the doctor?" And I said, yeah, I am. And she said, "Well, what's going on in there?" I said, "I don't know. She won't die." "Who are you?" Well, she's a friend of the family's, and we went through the same, no, everything's fine. She said, "Well, we just couldn't get it." And she told him, she said something, she says, "You know, she had a daughter once." And I said, "Really?" I hadn't heard that from these guys at the bedside for the last 2.5 weeks. She says, "Yeah, they parted about 25 years ago. I'm not really sure why. Do you think that would have anything to do with it?" And I said, "Well, I'm fresh out of ideas. Do you know how to get a hold of her?" And she kind of rifled through her handbag. It's about twice the size of that. And it was amazing to me because she kind of, and pulled out this kind of raggedy piece of paper. She says, "I haven't talked to her in about 10 years, but I think this is her number." Okay, there was no name on it, just a penciled number, which after 10 years of being stuffed in her purse. I was just impressed with their filing system that she could pull it out like that. She says, "This is the last number I had for her." So I walked in the room, picked up the phone, dialed the number, and the lady answers the phone, and she said, I said, "Is this so-and-so?" She says, "Yeah." I said, "Well, this is Dr. Mulder, calling from Alive Hospice in Nashville, Tennessee, and I just wanted you to know that I've been taking care of your mom." And she came into our facility a few weeks ago. She has cancer, and she's very, very close to the end of her life. And I thought you'd want to know. I know that you guys had separated at some point in time. I don't know why. Don't need to know why. I'm grateful I was able to track you down today. I didn't know if you might want to say something to her. She's not been responsive, so she won't talk back with you. But if you'd like, I can put the phone up to her ear and you can say whatever you want. She said, "I'd really like that." So I did. I put the phone next to her ear and could hear the little chitter chatter. So I'm thinking there, I'm so tempted to hit that speaker button. What do you say to somebody after decades of estrangement? I didn't. So it wasn't 1-2 minutes into that chitter chatter that we start seeing the tears come down this lady's face. Of course, the scientist in me is saying, "Oh, where's that coming from?" She's had nothing in a month. And of course, and it wasn't just a drop, it was just a flood. It was clearly, very emotional, very, very touching moment as we witnessed that. And so the chitter chatter stops, I put the phone back up and I explained to her what we all just witnessed. Thanked her and she thanked me when I hung up, and 5 minutes later she was dead. That was no surprise in terms of the timing of that. So, do you think that the will to live and resignation has any impact on timing? You all have stories of how that happens. It just emphasizes the importance of allowing people to talk about the meaning of their journey. Because it's not that people give up, I don't like that term, but the understanding of what's going on and how they define meaningful life, and to be able to make a determination, I've lived well, and I might not have lived as long as I wanted, but I've lived well, and so it's time to move on. That produces a whole lot of other sorts of conversations. So, so that will to live. Family considerations. I sort of touched on that under agendas. High expectation of cure versus comfort measures only, and the types of influences that we have there. One of the things to take a look at is how many fingers are in the dike. You know, who all are you all dealing with when you're navigating a patient? Understand there's an awful lot of other people involved, and the patient may have primacy in terms of their helping to direct the care, but the family members do have validity. Their input counts, and their feelings count, and their perspectives count. So we have to acknowledge those. How we ultimately make decisions may be a bit complex, but so understand that there's family considerations in there. Intuition, and this is to me is one of my favorite ones. In terms of understanding prognosis, how does intuition fit into that? I once had a physician that didn't work for me very long because he really thought he could make rounds from home. He would call into the facility and talk to the nurses, and the nurses would tell him what's going on, and he would make his judgments and his determinations from that. I said, no, you got to be there. Presence, presence, presence. So vitally important to be there. And you will get to know these patients, and you will have intuitions. You will, you will take a look at how much they're eating, how's their breathing, what's their level of activity, what are they able to do now that they couldn't do when you were in the home last week. All these sorts of subtle nuances that really begin to give you the idea that, you know what, we're starting to decline more rapidly this week than before. And then the last bullet on that slide is mystery. I don't do a lot of quoting the scripture, but in your book, they were all written, the days fashioned for me, as yet there were none of them. There is, there's a mysteriousness to the whole issue of life, death, living and dying that we will never understand, never appreciate. So don't ever believe that somehow you can ultimately understand it all, either the aspect of prognosis or how someone negotiates their terminal process. Okay, so that's just some thoughts on prognosis. The next one, the slide, you can't see too well, but really here's the basic take-home message on this particular slide. We're going to say just a couple words about palliative care. We see that little arrow at the left side of that graph that says birth, and the box at the top that says wellness and prevention. So that really kind of fits with that top box on the second slide that we looked at there. People want to be well. But for 90% of us, we're going to get a diagnosis, a condition, a circumstance, a condition that's going to be part of our medical record that we know is going to impact our journey, that is going to either be a terminal something somewhere along the line, or is going to somehow influence our quality of life. It might be, something as, and I'm going to say trivial, as hypothyroidism, or something perhaps not less trivial, but easily manageable, hypertension or diabetes. These are things that we're diagnosed with that are going to have an impact on us as we live our lives. For others of us, we're going to have a specific diagnosis. We're going to be told we have congestive heart failure or some sort of cancer that may or may not be treatable. Something, neurologic diseases. I mentioned my ALS clinic that I work. Multiple sclerosis, MS. Kids, I take care of kids with cystic fibrosis, muscular dystrophy. From this day forward, life changes. Life changes. And how are we going to really bring about the resources of the medical care system to make sure that they continue to do well and live well? So you see two boxes about diagnosis. Of course, curative and chronic care. To the extent to which we have the ability to cure, we're going to certainly want to do that. And if not, then we're going to have disease-modifying therapies that we can bring into the picture as well. So we can continue to treat and provide management care if we can't do curative care. It is my belief that at the beginning of the diagnosis, the sooner that you enter a realm where palliative care can be provided, the patients do better. I mean, we've seen that anecdotally. Those of you who've been involved in also understand that. We now are getting some science behind that validates that. It's been about 3 years since there was an article that came out, and these were patients that at the time of diagnosis of stage 4 lung cancer were split into 2 groups. And the group, one group, the control group, was treated as normal for stage 4 lung cancer. Whatever normal oncologic things would be done, that was done, what we refer to as ordinary care. The second group also received ordinary care, plus they had a single palliative care consult at the beginning of the illness, at which time they talked about goals, values, understanding the illness, fears, all the things that are relevant there. Helped to design a plan, gave that back to the treating doctors. They didn't follow these people until they were all dead, because at stage 4 they're all going to be dead. You can't cure stage 4 cancer. What they found was that, and there were like a couple hundred in each group, it was a large sample size, that the patients that received the palliative care consult at the end of the time reported 50% less depression. They reported improved comfort control. They had fewer hospitalizations, fewer ER visits. So it was cheaper to take care of them, and they lived about a month longer than those that received only ordinary care. So my question is, what's not to like about this model? The earlier you get palliative care in to help to define those things, your job suddenly become a lot easier because you don't have as much of this hand-wringing at home, I don't know what to do, I don't know what to do. Will everyone lock onto that and really fully engage? No. I've got a family right now that is just agonizing, and I'm agonizing with them because they are so locked into a curative plan of care for their incurable 14-year-old child. It's causing them to make inappropriate decisions for the child. And the child is suffering as a result. And they know it. But I can't get them to get their head around the reality of the diagnosis. So not everybody locks in. But so that's a palliative plan of care in which we start looking at how do we live well. We don't replace curative or other sorts of remissive types of therapies. We don't change chronic care at all. Disease-modifying remedies? No, the palliative is to help to define the goals of care because then that will help to drive that. If the types of care we would do in terms of disease modification or a cure would be in large part driven by the values and the goals, which palliative care helps to identify. So for the patients that you're caring for, if you want life to be easier for you, take a look at the palliative resources that are available and try to negotiate access of those resources for the patients. You'll see then at the bottom box is just above that line where it says limited prognosis and it says hospice. Hospice comes into the picture when we recognize that we have a limited prognosis. By definition, Medicare definition anyway, and by our state licensing also, by the way. In order to be eligible to receive hospice care, patients need to have something we can't fix. And they need to have a prognosis that if the disease runs its natural course, we would anticipate that to occur within about 6 months. We already acknowledge that we're lousy at prognostication. And all the regulators understand that. But they can take a look and say, you know what, this patient, I just talked to a hospice doctor this morning, and he was kind of scratched his, they've had a patient under care for 6 years now. What did I think about that? I said, you mean as your friend, as your colleague, or as someone, who might be called on to review your case in front of an administrative law judge for not behaving yourself? I mean, I can look at this in a number of different ways. There are patients that we just sometimes don't know. We just don't know. Every hospice has long-stay patients that we could not have predicted. But we can take a look at the moment. We can take a look at the progression. We can take a look at the comorbidities, the tempo, all these other things that we just talked about to make a rational decision that yes, when I've done reviews, I had a patient once, and those of you who have worked in hospice will appreciate this one. She was 104 when she came into hospice care. She had end-stage dementia, curled up in fetal position, weighed less than 100 pounds, and in the process of moving, fell or was dropped, broke a hip, brought her to the hospital, determined they couldn't fix it, and developed an aspiration pneumonia. Okay, so 104, aspiration pneumonia, fractured hip, and end-stage dementia. What about this does not suggest that the patient is eligible for hospice care? Okay. Went back to the facility with hospice service, with hospice care, and her pneumonia cleared. It just, you know, they decided not to treat it, but it cleared anyway. The pain from the hip fracture seemed to get better after a couple of weeks. Of course, her dementia was already end stage. There was nowhere for that to go. So within a couple of months, she was sort of back where she was before. Developed a cubitus ulcer. But flipped her, and that kind of cleared after 3 or 4 months. Developed another aspiration pneumonia. That cleared spontaneously after a few more months. So here we just had this kind of piling on of comorbidities, and she got from 104, 105, 106. She was discharged by the hospice at age 107 for extended prognosis. And that was flagged as being an inappropriate admission and keeping the patient long beyond the expected anticipated prognosis. So sometimes we just can't predict these things. But that's where we bring hospice in. So I want to talk just a couple of words about palliative, and then we'll talk about hospice and specific eligibility, and we'll take some questions and still have you out here maybe a little early. So let me see, if you flip back to the, it would be the last slide on the first page where I had here, you know, really what is palliative care? Our focus is to relieve suffering and improve the quality of life for people that have things we can't fix. I refer to them as life-defining illnesses. I really like that term. It doesn't have to be life-threatening, it doesn't have to be terminal, but life-defining illnesses, that really is what palliative does. Palliative doesn't speak to prognosis. I mean, I can take people, I've got kids that I'm taking care of right now that I've told them, I said, I expect that you will outlive me. But that doesn't mean that they're not going to die from their illness, nor that they have specific palliative issues that need to be dealt with now. So improving the quality of life and relief of suffering, those are what we do. And we do that, you know, it's the active total care of the patients whose disease is not responsive to curative treatments. Control of pain and other symptoms, and of psychological, social, and spiritual problems is paramount. And then again, the same World Health Organization said that the goal of palliative care is achievement of the best quality of life for patients and their families. And so what we do in palliative care is twofold. If we're going to improve quality of life, that sort of implies that we're pretty good at symptom management. So we are going to be very, very aggressive in terms of how we treat patients. We're going to know the latest and the greatest ways to relieve pain and nausea and delirium and breathlessness and whatever. I've told a patient this morning, there's not a symptom, I've been doing this for close to 30 years, there's not a symptom that you can come up with that I haven't encountered. Okay? And somewhere in my bag of tricks, I've got a something for that. So we need to know, we'll relieve your symptoms. Second thing we do is we help them plan. Given the nature of this disease, what we can expect to go on, how do we best plan for that? We may not know how to cure that, but we know what it does, and therefore we can stay a step ahead and help to present a unified front as far as how we deal with the complications of that. I have patients that talk about, I got to fight. I really don't like that analogy very much. I had a conversation, I have this conversation with my ALS patients all the time. When they say, well, I'm going to fight this disease, I say, okay, here's the deal. You fight this disease, you're going to lose. Okay? You can't win that disease. The disease will ultimately. But let's fight for the disease you want. Imagine someone just dropped a huge rock in front of you, and that's not moving. Okay? You can go up there and you can fight it if you want, or you can figure out how can I creatively just ignore it and work around it. Okay? Amber, I thought, had, for me, the best line of the day when she talked about you know, the fact that this disease, I need to find out who you are outside of this disease. I just love that line. Tell her that I love that line. I'm going to use that. Okay. So I hope she doesn't have copyrighted. But that's a great line. Who is this patient outside of the disease? So how are we going to fight for the life that you want and work around the issue that there's this disease standing in the middle of your life? So that's kind of how we do that. And I'm not going to spend much more talking about palliative care unless you really want me to. Let's talk about hospice. Now, usually I don't read off the slides, but I put these slides in here specifically just so those of you who had less direct involvement with hospice would really understand. It's a team-oriented approach that was really covered by, you've actually heard from the voices of those who are on a hospice team. A team-oriented approach to expert medical care, pain management, and emotional spiritual support, expressly tailored to the patient's needs and wishes. Support is provided to the patient's loved one as well. And then the next slide, the focus of hospice relies on the belief that each of us has the right to die pain-free and with dignity, and that our loved ones will receive the necessary support to allow us to do so. Focuses on caring, not curing, and in most cases, care is provided in the patient's home or home-like setting. It's consistently misunderstood to be as giving up, to be provided only when all hope is gone, but in reality, it is precisely the hospice environment which provides the greatest opportunity to ensure comfort and optimal quality of life when cure is no longer possible.
I think some of those lines that he's telling you are part of how you have this conversation with people about when you're starting to introduce it. Another great thing I've learned from Amber is with this giving up hope, that people view it that way. It's not about giving up hope, it's about changing the hope.
When people tell me that, and that's a great point, is when they'll say, well, I don't want to talk about hospitals. I don't want to take their hope away. Mm-hmm. My question to them is, well, what hope is it you're talking about?
Mm-hmm.
And that usually brings about some silence. Well, hope that they can get beyond this disease. I say, but they can't. That's not hope that you're instilling in them. Maybe false hope. But that's simply untrue. That's not reality. You need to be honest. And when you're on, when I get asked to do a consultation in the hospital, and the story is something like, well, they need hospice, but they won't listen, they won't accept it, so they want palliative instead. I don't know if that's an either or, it can be both. I said, I love those, because we'll create a great palliative plan of care and have them just lapping to get out of hospital, or to get into hospice when they get out of the hospital, because of how we present what it is and what it will do for them. One of my favorite stories was a 36-year-old guy, young guy, had widely metastatic melanoma. It was brain, bone, lungs, everywhere. And I was seeing him for some pain issues in my clinic, and this is again down in Tennessee. And they were in, and his wife was in, and his parents were in. So we were talking about the nature of the disease and what we could expect ahead. And I said, it sounds to me like you could use some help with pain issues. You're 45 minutes away from the clinic, and perhaps we could arrange to have a nurse come out and help you with the with pain management, connected with me. They should be out there once, twice a week, just to stay on top of it, because coming down here every 3-4 weeks is not working. And you said, that would be great if we could get on top of that, because I feel miserable. And in fact, it was his level of misery that caused his oncologist to say, I can't treat you anymore. This is Vanderbilt. They have all sorts of clinical protocols and things like that, and trial that might have been eligible for, but his level of poor symptom control was such that he couldn't do that, which is why he was in the clinic in the first place. So, and I said, I'm kind of watching the family dynamics here and the strain that this clearly is causing on your marriage and the challenge that you already reported with your young daughter. Maybe we could have a social work connect with you to help have those discussions, conversations, and negotiate some of this conflict, and to really get you on a track so that you're all on the same page moving forward as you're approaching this process. And they said, wow, that would be great. And I said, I'm a little concerned. As we've been talking, as you seem to have distanced yourself from your faith. And I can sense that anger that you have toward God, and understandably so. I'm wondering if it might be worthwhile to have a chaplain sit down and talk with you through some of those issues, so you can at least be at a different sense of peace about where you are with your faith walk. And I said, whoa, yeah, that would be really cool. You know all these people? And I said, yeah, I do. Actually, they're part of the hospice team, and I think they would be perfect to help you with this. Now, as soon as I said the hospice word, wife falls off the off her stool, and the parents are gnashing their teeth. Oh, no. And this, by the way, is after we have already established the fact that he knew he has but a few weeks to live. Okay? And so it wasn't like I'm telling him they was going to die. He already knew that. But somehow the specter of hospice was very, very frightening. So I said, I don't know what you believe hospice to be, but what I've just explained to you is what they do. We're not taking any options away from you. We're just bringing in some experts to help you deal with the reality of how this disease has impacted your life right now. They ultimately agreed. The rest of the story is kind of a fun story. I don't necessarily talk this about inpatient environments because this doesn't happen to hardly anybody. What does happen, we got his pain under control. Family was reconnected and they were strengthened. He started getting his strength back and his energy back, and he started feeling much better. Wow, even having this cancer, he was doing better. Interestingly enough, his wife got pregnant again. They had another baby. In response to how well he was feeling, he went back to his oncologist, and his oncologist said, yes, you're doing well now. I can get you in this trial. That was about 10 years ago. Okay? He's still doing very, very well. Okay? Hospice saved his life. Doesn't happen very often. But you sell to people what the process does for them. Forget the word. I don't care about much about the word. But, so I typically don't have problems. I always start my discussions about, tell me what challenges you're having. When I go in to see somebody in the hospital room, or I'm seeing them in the clinic, tell me what's going on. Tell me how this is affecting your life. What are the doctors telling you about prognosis? What are your expectations? What does your heart tell you versus what the doctors are telling you? So we really kind of, within a relatively short period of time, are able to really establish that they know they got something they can't fix. Let's talk about what kind of burden this has laid on your life, what kind of challenges you're having as a result of this. Well, here are some resources that are available to you to help with that. And I simply outline all the things that hospice does that would be of great benefit to them. It makes it much harder for them then to object to that. And sometimes I'll say, if I start to see a little bit of resistance or defensiveness, I'll say, a lot of people don't fully understand what hospice is, or what they do. And they fear that it means just last days, death and dying. And I got to tell you, they do that work better than anybody. But that's not all they do. The earlier and further upstream we can get you involved with them, the better you're going to do, the better you're going to feel, and probably the longer you're going to live. So, what do you think? Give it a try. Hey, if you don't like it, you can always check out. Just tell them not to come back. It's not that big a deal.
And with the model we just set up, if they either get better or they change their mind because they haven't been discharged from your program, it really is a very smooth transition back into your services.
So as we talk about eligibility, there are a lot of easy ones out there. People that come in, they're actively dying, that's an easy one. People that have really advanced cancer, that for the most part is an easy one. Stage 4 cancer, virtually any flavor, is by definition has a limited prognosis, and so they probably qualify for hospice. But eligibility becomes a little bit dicier when we're talking about non-cancer diagnoses. And so we'll just talk about 2 or 3 or 4 of those, so we have an understanding of where does eligibility fit in with these particular patients that don't have a cancer diagnosis, but it appears that they're dying as a result of their underlying illness. So dementia is a big one, and I don't know yet where Tandem is going to be focusing their efforts as far as what particular patient populations they're going to be looking at. My guess it's going to be kind of across the continuum of illnesses, really in terms of challenging things. Dementia, I'm just going to mention because that's a particularly challenging one in hospice. But at the end of the day, it really is fairly simple. We have a scale that we measure the level of their progression through dementia. We call it a FAST scale, and I always forget what the FAST stands for. It's a functional assessment something T scale, whatever it is. But it's a series of 7 steps. I think most of us in this room are 1s. I may be a little bit outside that, but I don't know. By the time you get to 6, when you go through the 6 and the subsets of 6, A, B, C, D, E, that really has to do with loss of ADLs. So we're now seeing some inability to really care for self. By the time you get to 6E and you cross that threshold into 7, you really are completely dependent on somebody else for all of your needs. And by then, your cognition is severely impaired, your memory is gone. And when you start subsetting subsetting 7, it has to do with things like only a handful of words. They're not used in a logical sequence. That's A. And B, you've lost your language skills. 7C, you now can't sit up. Or I'm sorry, you can't ambulate anymore. And then when you get to D, you can't sit up unsupported. And E, you lose your smile. And so all these sorts of, so as you progress through. So in order to be eligible for a dementia diagnosis, you need to be in the 7s. Some people will shy and say 7A is okay. Some say 7C just to be sure. But you need to be in the 7s. But most important, and when I'm reviewing charts and I'm looking at eligibility, the thing that they miss the most is that you need to have a comorbidity that impacts prognosis. So someone who has had an aspiration pneumonia has impaired from that, which means it's not getting better. Someone who has had not just a lower urinary tract infection, but a pyelonephritis or upper kidney infection or sepsis would count. So someone who has a stage 3 or 4 decubitus ulcers, recurrent fevers, poor nutritional intake, someone who's lost greater than 10% of their weight over 6 months, along with that dementia, makes them eligible for hospice services. The key with that is that we need to kind of follow along, because if that comorbidity goes away, let's say they've been brought in because they've been declining, seem not to be doing well, they're not eating as well, they've lost weight, now have decubitus ulcer and this profound dementia, and after about 4 or 5 months, boy, that stage 4 seems to have cleared pretty well. They were dropping weight, but now their weight is stabilized. They may not be eligible for hospice anymore. We may have to discharge them for extended prognosis. So we have to keep that. So the easiest way to think about dementia is they got their profound dementia and something else that impacts their life expectancy. So by the way, if there's any questions that come up while I'm speaking to them, let me know. Probably two of the really challenging ones are heart disease and lung disease. Heart disease, someone who has end-stage congestive heart failure, again, the lines in the sand that the government has drawn looking at that is a left ventricular ejection fraction of 20% or less. So if you have that, that's pretty good evidence that someone has a limited prognosis. On maximum medical therapy, so they're receiving all the medicines that we can possibly do to help to remedy that. Functional impairment, we use what's called a New York Heart Association scale. And class 4 is dyspnea at rest. So even just being at rest or with minimal conversation. So you've got someone who meets those criteria, they probably are eligible for hospice admission on the basis that. Even then, you need to kind of watch how they're doing over time. I've had patients that have met those criteria. They seem to do okay. All of a sudden they seem to be up and walking around a little bit. I don't know, that doesn't make them ineligible. But if we're looking at something that looks more chronic as opposed to progressive, then we have to think about that. I mean, on the dementia side, I've been in nursing homes. I've seen people who have been in a fetal position for 6 years. They just don't change. You put a little spoon next to their mouth and they'll slurp up that applesauce. They're not terminally ill. I don't know how long they'll live, but there's nothing that suggests that they're on a trajectory. So what does that trajectory look like? And with end-stage lung disease, it's the same thing. Some people look at the numbers. What is their resting O2? That may be relevant. If any of us right now, dropped our O2 sats to 90, 88, we're going to be on the floor. We're got a hard time leaving the building because of our shortness of breath. I've got people with COPD running around at 68 playing golf. So the O2 itself doesn't tell the tale. What is their functional limitation? What are they able to do? Are they in dyspneic at best? Or what is their functional capacity? What are they able to do? What sort of comorbidities have they had? Repeated hospitalizations is always a good clue that this is someone who is, they have an exacerbation and they're rescued and recovered in the hospital. 4 weeks later, same thing. They get a little cold. They sneeze and suddenly they can't tolerate it. Very, very poor reserve back in the hospital, on IVs in the unit, sometimes on a vent, sometimes not. Sometimes non-invasive ventilatory support. and then they kind of get them back to the baseline or slightly below, and they're back home. These sorts of folks are probably eligible for hospice services, but to the extent to which they're saying, you know what, I don't get better when I'm in the hospital anymore, I don't want to go back. We can sort of predict that they're going to have another one of those episodes sometime in the relatively near future. And we'll be there to support them, to help to make sure that they don't suffer, that there's no distress. We treat their pain, we treat their dyspnea, and we help them to have a meaningful life experience. So you look at the rapidity with which they continue to access the healthcare system. So probably those three big ones that we get are dementia, heart failure, and COPD. I'm trying to think if there's anything else that I want to talk specifically about. There's other, renal disease certainly, and liver disease can be a little bit dicey. It's really, really tough to prognosticate on the basis of liver failure how long someone's going to live, because it's not necessarily dependent upon blood tests. It's not necessarily dependent upon how yellow they are, and it's really, really challenging sometimes. Again, we'll look at that in terms of their cognition, their nutritional status. Nutritional status is always a great bellwether. And again, they've really looked at the greater than 10% of their body weight over a 6-month period of time as being a good criteria to say there's something going on nutritionally with this person that they can't survive very long, regardless of what disease they have. So I'm going to pause there and ask what kind of questions you have. For you guys, what didn't I mention about hospice eligibility, hospice stuff, that you would want these navigators to know?
I think that the only thing is just a reminder that these are, Dr. Mulder gave you all these things, but you don't necessarily know for sure. To please call and we can come out and do a visit or have a conversation with you about that and get into some of the details of your specific patient, because some of them
Correct.
can have a couple different things going on and they don't qualify for one or the other, but yet they could very well qualify for hospice if we put them both together. So I guess that's just a reminder what Sarah mentioned earlier. Please feel free to call. We'll be more than happy to have those conversations or come out and talk with your families if you so would desire that.
And to answer your question, Joni, it was already answered, but no, you don't need a doctor's order. Just have someone come out and do that evaluation. You really don't. And we're happy to have those, because what would grieve us the most is to know that there's someone out there that could use hospice services, could make life better for them, the family, and you, and they're not accessing it because someone's trying to fit something in a box and they couldn't make it fit.
Right.
So,
or the doctors are less ready than the patient.
Well, doctors, I don't think any doctors in the room. Doctors sometimes don't know what they're talking about. And when we talk about, when we look at prognosis and we talk about agendas, physicians have agendas too. And their agendas may not necessarily always be in fitting with what the patient's best interests are. I got in a consultation once, went in to see a patient, this was their, I think they'd been in the ICU 71 days after an open heart that had complications. And they were still in the vent, and we're not going to come off the vent. Patient was still conscious and decided this is not the life I want to live. And so they brought that up to the physician, who, a foot away from the patient's face, yelled, according to the family, the patient, and the staff there, "I did not invest this amount of time in you to let you go, so no, you can't."
Wow.
Okay. That's a pretty dramatic example. But there are, what happens much, much more commonly, if you take a look at the cancer field, and patients come in and they're desperate, they have a cancer that's been diagnosed, they're scared to death about that, and they're talking to the doctor about what else they can do to treat the cancer. And the physician says, well, we've done the first line therapy and that failed, and so we go to second line therapy and kind of had disease progression despite that too. They went to third line therapy. And so now the doctors are saying, boy, they want, I've got this chemotherapy drug over here, really is not indicated for this cancer, but I went out to see a 12-year-old girl. She had a rhabdomyosarcoma, which is a tumor of the muscle, metastatic to her lungs. I was out to see her for pain issues. And I'm going through a med list, and I see an oral chemotherapeutic agent on her med list. I'm saying, that's strange. I'm not an oncologist, but I deal in the cancer world all the time. I had never seen that drug for that particular cancer before. So I called the oncologist and said, I'm very, very curious about this because I'm not sure what role that drug has in the treatment of this cancer. And he just, oh, it won't do anything for cancer. I said, then why is she on it? And he said, well, I couldn't do nothing. So a lot of physicians really have a very difficult time with that. Again, once we help the patients and the families clarify their goals, it becomes very, very easy. And I have these discussions, and I can tell you that in my 8 years in Grand Rapids, I've not had one oncologist who has ever been either frustrated or angry with me when I've come back to them and said, I just saw so-and-so, and here's where they are in the context of their illness, here's what they want to do, and here's what they don't want to do anymore. They'll finish this, but they don't want to go to third round. And they typically say, that's fine, because I don't think it's going to help them anyway. But they'll continue to do it if the patient and family demands it. And the patient and family will only demand what they suspect or believe, and it's on the basis of treating something as opposed to doing it as a goals or values-based process. That's why it's so important to understand what their goals are, what their values are. And you're in a perfect position as navigators to help them to define that as you develop a relationship with it. It's one of the cool things about the program. What other questions do you have?
Do you feel like you're good on how to have the conversation? Do you want any other tips from Dr. Mulder or from us about how to... The selling the program before saying the name is often very helpful.
Yeah. What we're going to do and why.
I just have a message from Lee. He left me a voicemail and said, I hope you get this before you leave. He stopped down at the Red Hut to get a hot dog after he had left here. And he said,
what a
you
great
wouldn't,
idea.
huh?
What a great idea.
Anyway, he said, you wouldn't believe it. I was in there and these two ladies were talking about Tandem 365 and that somebody is going to come out and be talking with them about hospice this week. So he said, do you think that's a bad thing that this happened? It's like, oh, it's a voicemail. So I just thought it would be nice to share with you that hopefully that this has been helpful. So when you do have to have those conversations that you have some extra resources and information and know that we're supporting you too in those.
I'll just close with one other story. I was out to one of the nursing homes in town, and I was seeing a lady who was not sure. I mean, she was still ambulatory, and she was still, but she couldn't live on her own anymore. She had some specific needs, and I was over to visit with her, and I went to her room, and she wasn't in her room. And I went to the nurse. I was a little alarmed. I went, where is she? She did not expect her to go anywhere. She says, oh, this time of the morning, she goes down to the dining room and has coffee with 3 of her friends. Oh, okay. So I walked into the and she turned out, she saw me, and she turned to her friend and says, this is the doctor I was telling you about. And all 3 of them says, oh, can I have that hospice thing too? When can I get in hospice? I want the hospice thing too. And it was just, she was perceiving the benefit and telling her friends, this is what I get as a result of being in hospice. And her friends were saying, that's great. And everybody ought to be approaching it that way. Okay. Well, that's all I got. So if there's anything else that you need, I'm very reachable through Faith Hospice is the easy way to reach me. And we're committed to this process. And I recognize that as you kind of go through your days, you will find some things that are kind of sometimes curious to you, confusing to you, and if it relates to something that, or you're just trying to, I don't know how to talk to a doctor. Certainly, you've got a line of authority, but I'm more than happy to do curbside consults with you guys if you just have a question about a medical presentation or something like that. That if I can be of some assistance to you. We want this thing to be successful, and I'll do whatever I can to make that happen.
Great, thank you so much.
Okay. Thank you.